All right. I didn't have that in my lectures until the first years. We had a pool party at Dan McNeil's house the first year. None of them wore sunscreen. And we were out there all afternoon. I kept saying, are y'all going to put sunscreen on? And so they came into class just beet red. So I made them sit through a lecture on sunscreen.
Obviously, that's the redhead in that mix.
I don't think we did. We had some blondes, Larry and Brad. No, Lichen was a redhead. We had one and two. Why are you laughing?
You said blonde, Larry said Avoidance.
Larry
had many names.
We're not
Larry.
Yeah, all right. Okay. So we're going to talk about some specific drugs in terms of drug reactions. So here kind of gives you the breakdown of the big three: drug-induced urticaria, hives, the macular-papular eruptions, and the fixed drugs. So what you'll see up there is the majority are caused by what? Antibiotics. And the two classes of antibiotics that are most likely, penicillins and sulfonides. Okay. For the macular-papular, you see a lot of yellow, so that's the anticonvulsant drugs. So what would be some of in that category? Carbamazepine, lamotrigine, valproic acid. Those are the big ones. Dilantin would be another one. Okay. Let's see. You see under the drug-induced urticaria that you see the NSAIDs. So NSAIDs are unlikely in most people to cause a problem. The problem is they're so widely used by so many people. So we're going to talk about the different types of problems you can see with the non-steroidals. We're going to do that next. So you've got this slide in color if you want to go back. Okay, let's do it. So if you look on page 2, so non-steroidals can give you either a pseudo-allergic, so it looks like an allergic, but if I said pseudo-allergic, you know it means it looks like allergic, but it's not, which means it's what is it not caused by? It's not IgE mediated, okay? The allergic for NSAIDs is IgE mediated, and IgE mediated are usually what type of reactions? Ones. Good, good. Okay. So in terms of the NSAIDs, it can go either way. It can be that they are allergic. If they're pseudo-allergic, it's usually due to the effects of non-steroidals in general. There's some kind of change that happens in the metabolic pathway that NSAIDs affect. So with pseudo-allergies, they may have the reaction to ibuprofen, but then they take naproxen and they have the same reaction. Okay. So it's usually due to the effects of the COX-1 effect, not so much the individual drug. Okay. When you get to the allergic, it's a specific drug. They're allergic to ibuprofen, but they take naproxen and they don't have any trouble with it. Okay, see the difference? All right. So there are, under the pseudo reactions, there's 4 types. They are either going to be predominantly skin reactions or they're going to be predominantly respiratory. And in there, so that's the thing, that's how in your mind you should categorize it. One is almost all cutaneous. 4 is a mix of both. The ones in the middle are primarily respiratory. So keep those two systems in mind as we go through. Pay attention to the timeline. So if I give you a question where I've given you and described, here's a person coming into emergency care and here's the history you get, timeline would be important. An allergic reaction is going to take place very quickly, so that's in that other group. The pseudo-allergic are more delayed, so they will be anywhere from 30 minutes to 3 hours. The other will be is look at what the underlying diseases or conditions the person has. It'll give you a clue as to which of those reactions that's taking place. Under allergic, there's two types. They call them type 5 and type 6, and they are more a degree of reaction. So 5 is a milder allergic reaction, 6 is an anaphylactic reaction. Okay. I'm just giving you the whole scope. So there's 6 different types. 5 and 6 are allergic, 1 through 4 are pseudo-allergic. Okay, let's go through the pseudo-allergic individually. Under pseudo-allergic reactions, that heading, if you'll go down to second bullet, usually the people have one of these problems. They have asthma, chronic rhinosinusitis with nasal polyps, or they have chronic urticaria. Those people that have those conditions almost always have a high atopy, or a high allergic component to their disease. So it usually what feeds into asthma. Those are going to be the people who come in with aspirin allergies. Remember, the people who tend to be 10% of asthmatics have true allergic reactions to aspirin. And what are the cardinal signs for them, or conditions that they have? Asthma,
Allergic rhinitis.
chronic sinusitis with polyps. That's the highest group. Okay, they're the most likely to have that aspirin allergy. So type 1. Type 1 is pretty much just respiratory. Okay, so look at the symptoms: rhinorrhea, nasal congestion, eye swelling, injected conjunctiva, bronchospasms, laryngospasm. Okay. So those folks, they may get hives and angioedema, they may not. They also may have other systemic symptoms, maybe GI, because of the histamines that are in the GI tract, but they are delayed. They're the most delayed, 1 to 3 hours after taking. Sometimes these reactions are so far apart from when the drug was taken that people don't ever put them together. Sometimes people will have these symptoms, think it's a worsening of their asthma, or other respiratory disease they have, and never put it together. So not uncommon to be missed. So 2 and 3 are more skin, cutaneous. Okay? The difference between 2 and 3 is people have chronic urticaria and those who don't. Have you talked about that condition, just having a constant hives? Okay. So there are some people that have hives all the time, and we call it chronic urticaria when they have hives present the majority of the time for more than 6 weeks, I think it is. So for those folks, they are the ones who tend to get type 2, so they can get a worsening of their urticaria and angioedema. So where's angioedema going to show up? In the face, mostly lips. Okay. So these folks, 90 to 30 minutes. So they're probably one of the most fast reactions of these 4 types. Next page is cutaneous, but these people have no history of chronic urticaria. So that's the difference between 2 and 3. So you know in your mind you should be starting to build your pathway of someone coming in and you suspect it's a non-steroidal. It's the same kind of timeline, 30 to 90 minutes. They may just have angioedema, they may just have hives. Sometimes they will have, and under that third bullet, look at the description. So they develop hives and or angioedema, or they just have intermittent, unexplained urticaria. So that's not uncommon for people. They'll get hives, they'll get a maybe in the same part of their body, maybe the same place all the time. But they're never linking it back because they don't recognize the pattern. Patients under that fourth one, an important one, I'll come back to you, Jenna. So an important one here, for an allergic reaction, can you have it on the first time you take a drug? No. But in this type, you can. It could be the first time they take a non-steroidal, they have this reaction. That would be unusual. That would set it apart from a true allergic. Okay. That's why they think it's a metabolic abnormality. Okay, Jenna?
So would a patient kind of say, oh, I usually have hives, but they're just worse? Or how would you know?
Yeah, they could. They could. Or they put it together. I took this, this happened. That doesn't usually happen. Type 4 is kind of, it doesn't fit anything else, so we're going to make it type 4. Type 4 is variable. It has both respiratory and cutaneous. The timeline can be variable here, so it can be very early onset after they take the non-steroidal, or it can also be some time out from when they take it. That's about it. So again, it's here, ibuprofen, you'll see it listed as the most likely agent. That is because it was the first agent. So it can happen with any of the non-steroidals. Okay? Just ibuprofen's been around longer. Okay, questions over the pseudo-allergies. So look for the big difference. Compare and contrast the allergic and non-allergic, and then look at timelines, look at who's most likely, what other diseases, and then if they've been exposed to a non-steroidal in that time frame. Okay, the allergic reactions, these are IgE mediated, so type 1, you got that, that's good. So this is usually one drug, one non-steroidal, and they've taken it before, didn't have any problems with it, second time, third time they took it, then they had the reaction. Okay. So the type 5 is the milder, so they have hives, they have angioedema, but they may not have anaphylactic reaction. So what would anaphylaxis be? Airway closes, so they have trouble breathing, they can die, okay, so more severe. All right, so this type 5, it can be very quick, within minutes. They usually don't have underlying conditions that would make you think about that being more susceptible. Next page. Again, this is a non-steroidal. This is anaphylaxis, so type 6 would be the most symptomatic. So the shortness of breath, the wheezing, the bronchospasm, laryngeal edema. So what do you do if someone has this? Because they're everywhere. So you can use Tylenol. It says in there that Tylenol at higher doses is COX-1 inhibition, but that is a lower threshold, a much lower possibility. That second bullet is really good. Teach patients how to read a label so that they can avoid them. They always are going to have to look at it, because you know how many combination products, you know how much I dislike those combination products. So being able to recognize a non-steroidal, it would be important there. The other is to refer them to an immunologist or an allergist. Okay. Questions about those? It is warm. Are y'all not warm?
Yeah.
Do you want the fans on? Sure. Have you been running the fan?
No, it was cold.
It was cold?
It was really cold.
Yeah, you guys have we all heated it up. Turn those in the back if you want. I'm going to turn this here. Do you want me to make this one go back and forth? Does it bother y'all? Who has the giggles today?
We're very exhausted.
But I know this is your favorite time to listen to stuff. Okay, there is I put this table, I found this table, I thought it was good. So It outlines the different types of non-steroidal allergic reactions, and it's just a nice little outline, another way to visualize it. So that's what that is. Did I put it in your handout though? I may not have. Okay. So you know it's a bit, oh, sorry, I plugged it in and then it was requested that, so I just want to make sure it's good for it.
I'm sorry, you spent all the work to plug it in. I'd hate to see it go without.
It was because they're giggling, and I don't know what's wrong with them.
Michelle?
No, it's just out of your. No, I don't care. It's just not important.
Hopefully you're not reach.
You can giggle all you want.
Thank you.
Do you want to trade spots?
Okay, let's look at phototoxic and photoallergy. Did you talk about both of those? She didn't mention them. I saw them in her. So, there are drugs that will cause phototoxicity, and there are drugs that will cause an allergic reaction when the skin is exposed to the sun. The difference is with the phototoxicity, it is dependent on the concentration of that drug that gets into a certain part of the skin. And then when exposed to sunlight, you get a toxic reaction. Photoallergic means that they've had an allergy, allergic to the sun's reaction with that drug in the skin. So they're very different. Okay. So this is a non-allergic cutaneous response. So it goes down through there and talks about that a certain level has to accumulate in the skin before the sun's interaction with it will cause this toxic reaction. It's UVA light that does it. Because you remember which one gets, you got UVB and UVA, right? Okay, which one gets furthest down? A goes the longest, and B hits the surface. Okay? That's important when we get to sunscreens. So, the severity then will be proportional to the dose. So the more people are taking, the longer they've taken it, the more likely they are to have this response. So if you look down through there, you can see there's quite a few drugs that will do that. Tetracycline is probably most notable. Thiazides will do it. And you'll see it a lot of it. Older folks, it'll be just where they're working outside and it just where the sun hit their wrist or their hand. Sulfonamides, fluoroquinolones, the non-steroidals, piroxicam and ketoprofen, the more likely. Phenothiazine, Sorlins, I don't use Sorlins very much anymore, but they're skin topicals. Riziofulvin, roniconazole, retinoids, and that applies to almost all the class of retinoids. Tar compounds, St. John warts, and amiodarone. You had to ever guess a drug that's going to cause us a reaction, you choose that one. Okay? So, it does not take a lot of sun exposure. This will look like an intense sunburn, and it really is painful. You can, just like with a really bad sunburn, you can get blisters that'll form in the damaged area. There's also, I just brought up the tar toxicity because it also fits in here, but your roofers, your people who work on roads, can also get a tar sensitivity. That is very similar to this. It will cause a toxic reaction. So, this is a child who has had tetracycline and has gotten in the sun. So using a sunscreen that has to do UVA. So not all sunscreens will cover UV. They have to be broad spectrum. If they say broad spectrum, then they will cover UVA and UVB. So doesn't it look like a sunburn? Mm-hmm. So it says it's confluent. What does that mean?
All together.
It's all together. Erythema on the dorsum of the hand after a child taking doxycycline. Here's another one. more intense, probably a little bit more prolonged. This is a little bit darker skinned woman's, but you can see on her hands the effects. Okay. Let's see. So that's phototoxic. I guarantee you probably see a picture like that on the test. So look on page 6, photoallergic. These are delayed hypersensitivity reactions. They'll look very similar to contact dermatitis. Have you had that yet? Okay. They have to be previously sensitized just like other allergies. So the usual ones are listed down there in the middle of the page. Quinidine, don't use that very often. Griseofulvin, not used very often. Quinine, not used very often. But quinolone, sulfonamides really common. Sulfonamides, PABA, it's actually an ingredient in sunscreens, are very similar in structure. And so we'll talk about PABA sensitivity when we get to the sunscreens. Ketoprofen, piroxicam. Some of the sulfonylureas, the drugs we use to treat diabetes, also they have a structure like the sulfonamide, so that they will also get a sunburn. So here's a man who was, so to orient, when first time I looked at this, I'm like, his wrist, his hand looks really weird, but it's his ankle. So if you're looking, he had a sock on, so that's the skin that was exposed between his, I mean, can't you just see him out in his yard with his pants hiked up and his short socks and his probably sandals. And he's got that little skin exposed, and so this is a photoallergic reaction. You can see some of the vesicles on there. This was due to ketoprofen gel. Some of it's knowing the drug. Here's another one. So how are you going to tell the difference between the two? Some of it will be drugs, some of it will be timing. How long have they taken? Because we know the other ones are more concentration dependent. Here shows, this is a nice little table that summarizes it for you in terms of, so most of them are going to be phototoxic. Amount of agent required is higher with phototoxic versus photoallergic. Onset of reaction, you see, is different. Immediate to delayed. Sun exposed only, both of them. Exposure to more than one agent, more likely with photoallergic. Resembles a sunburn or a dermatitis. And type 4 reaction versus not an immune related. Okay, so how do you treat sun avoidance? So on every tetracycline that gets dispensed, there's always a little label, auxiliary label on there that the pharmacist puts that says stay out of the sun. Okay? You should tell them, the pharmacist should tell them, the bottle's going to tell them if they pay attention to it. Sun protective clothing. So we have UV protective clothing, right? Any clothing will do it. Dry clothing does better than wet. Wet will let more light in than dry. Sunscreen's essential. Using a UVA. So when we get there, pay attention, because not all sunscreens will cover UVA. Most of them are designed for UVB. So you have to use a broad spectrum one to get that effect or get that protection. So symptomatic treatment, cool compresses, oral analgesics, most people will do okay. Don't use topical anesthetics, so like a Dermaplast that's got a benzocaine in it. Stay away from that. The photoallergic, you can use a steroid, 2 to 3 weeks. Why do we stop at 2 to 3 weeks? Systemic
Adverse reaction.
Systemic exposure, and this is talking about using them orally as well. Okay. So know the drugs, be able to match them up, be able to match up those those characteristics and pictures if available. Okay. Okay, anybody ever have this? As a kid, you didn't have it? No calluses and no, wow, okay. In my notes, or when I read, says it's predominantly male, but the only ones I've ever seen are female. So that's just my small. So this is pretty common, especially in kids. So what did you learn about it? Christmas tree in what? Pattern, okay, on the back. Herald patch. And then spreads. Okay. It's viral. So does it last, go away overnight, get it, and then go back to sleep? Yeah, so it can last a long time. What's a major symptom? Symptom, it is itching. It is really, it can be intensely itchy. So where is it distributed on the body? Trunk. Mostly front and back. All right, so on the top of page 8. So treatment, there's a variety of treatments. It's all going to be geared towards, for most patients, except for the most severe, it's going to be geared towards just controlling itching. Okay. So you can use steroids. You use them sparingly. You see a potency of 4 or 5. What was the example I gave you of 4? And which is higher potency, the 4 or the 5?
The
4. Thank you. 7 is not bad. 7 is the hydrocortisone. What's in the top? Clobetasol. Okay, most potent, super potent. I don't know what they're going to do. They've run out of adjectives. So what would you do if you got one more potent than clobetasol? I have no idea.
Extremely.
A very, very? Okay, so a medium potency. So give me an example of a level, or a category 4, or group 4. Okay, so triamcinolone, the 0.1%. What about a group 5? It's the one I told you didn't have to know. Fluocinolone is one of the cinolars, the lower strength. Okay, so you can use those. Here, because they're so widespread, I would say what you do is you're just going to go after the ones that are really bothering them. Use like a Q-tip to put it on there and try to stay within on the lesion. Warn patients, because these are mostly going to be kids, to wash their hands after they apply it. So it says to apply to pruritic areas no more than, or daily. Why wouldn't we just use it 4 or 5 times a day, however much we want it?
Because it doesn't work any better.
Okay, it doesn't work any better, and it increases their exposure to for ADRs. Okay, so 2 to 3 weeks. Most of the time, the intensity of the pruritus is going to be early on, and it's going to taper off. And some of them, those lesions will go away by then as well. You could use topical anesthetics. Now, the younger the kid, the more you want to be very cautious about using anesthetics. They're not recommended in kids under 2. They're not recommended over widespread areas of the body for prolonged periods of time. However, the nice thing about those anesthetics is that you can get them in sprays. So you could cover an area fairly easily without having to apply them. So I would say from an application standpoint, they're pretty nice. So that would be one, like a dermoplast. And they can be applied multiple times a day. The other would be to use counter irritants like menthol or camphor. So here gives you some examples. Here's the dermoplast. It's one of my favorites. I use it for a ton of things because it's You can spot on it, or you can spray it over large areas. So look at the different products you have up there. Tell me the different vehicles you see.
Gel,
There's a gel, cream,
spray.
and that's a spray also. So why would they use a gel? Why does a gel apply in this for these types of conditions?
Dry it up.
Okay, it spreads easily. It liquefies when it gets on the body, right? And it evaporates quickly. So it's not messy or greasy. So that was a good one. The creams, probably you could spread them all over, or you could put them on just localized areas. So that Benadryl gives you an antihistamine plus a counter irritant. What did I tell you about counter irritants?
They just kind of make you think of something, like it doesn't really work at the root cause, it makes your body focus on that.
The gating therapy, you can't think of two things at
Yeah.
once. So it makes you think about that, you can't think about the pain so much. So counter irritant. You think about the new irritant you put on and not the irritant you're trying to get rid of. Okay. I think at least when I went back and looked at the material, they also talked about oatmeal baths. That would be perfect, especially for a kid. And you could use it multiple times a day. So that would be a very good one. So look at severe cases. So this would be very unusual, but you could use an antiviral. So acyclovir has been used in severe cases. So this would be a really limited. Here with the acyclovir, you get fairly quick relief within 1 to 2 weeks. So for a severe, that would be a good thing. This is probably going to be more likely in your immunocompromised kids or patients. Don't use systemic glucocorticoids. Don't use an antibiotic. They're no benefit. And the systemic glucocorticoids are not recommended because it's self-limited anyway. All right. Did you learn anything else about this that I haven't mentioned? She didn't have much in her hand. I assume it was a she. I don't know. Lichen Planus. Very irritating skin disease. Gets everywhere. Intensely pruritic. I mean, drive you nuts. Pruritic. Can be on any part of the body. And it takes a long time to go away. Tell me what else you learned about it. So as opposed to what we just learned, it's mostly adults. Mostly middle-aged adults are going to get this. It's immune-mediated, and you get these lesions. The one up there in the corner is probably classic. So it almost looks like psoriasis because you get that silvery, but it's a real more purple sheen to it, and the plaques can be pretty large. Again, any part of the body they can get into. That has been proposed. It has never been fully. Did she tell you that in class? So what did she say? I can't hear you. Say it again.
Just to test patients for it because it's associated with the disease.
Yeah. It's never been a cause and effect. Has never been. It may be that they just find it and it's noted, but there's not necessarily, if you get Hep C, you're going to have it, or if you've got this, you're going to get Hep C. All right. Next page, let's look at treatment then, since you have the ClinMed. So, like we've talked about with other type of problems like this or conditions, you want to induce remission. So you want to get the disease or condition under control, and then you will back off therapy. So look at what they use to induce. So first of all, they're going to use topical steroids. And they're going to use the high potency. So, yes, the high potency. So you've got betamethasone and clobetasol. Those are both class 1. Twice daily, and you're going to do that until you get that disease to remit. Then you'll put them on intermittent therapy. So if you're in those zones where, like intertriginous or facial, then you drop the potency, just like we talked about a couple of days ago. Usually you do this for about 2 weeks, and then you usually start by just cutting the dose in half. And you just slowly continue to taper it. The goal would be to get them to about twice a week that you can maintain them. The problem with some of these lesions is, I said it looks like psoriasis, so if they're really thickened and hyperkeratotic, then they talk about that you could use intralesional. If you don't have that many, you've got one maybe large one that is not going to respond well. Remember that these vehicles will not drive the drug in. You have to either soften them up or use very high potency after an emollient to get the drug to go into the skin. So you could use triamcinolone acetonide. That's the drug we always use for intralesional. That's the steroid most people use if they're going to have to inject it right into the lesion. You'll see it's a limit, just like we talked about in gout. Remember we talked about you could inject into a joint, and the top amount was 40 there. And then it's about every 4 to 6 weeks, I think. Here, look at the side effects that we talked about the other day. So cutaneous atrophy, so either that thinning of the skin or that kind of scooped out appearance can occur, or hypopigmentation, especially if you're going to use it on the face. For a disease that's everywhere, the more you've got that you have to cover, we'll see this in psoriasis, then we'll go more to oral therapy. So anything that's localized, we'll try topical first, but the more it covers body-wise, then we'll go with oral. So here, the recommendation is to use a short course of an oral steroid. Then some of those lesions will go away with that, and then you can address the ones that are still remaining. So 30 to 60 milligrams for 4 to 6 weeks, so quite a length of time, and look at the taper, another 4 to 6 weeks. So you're looking at steroids for about 12 weeks. Has anybody come in to talk about phototherapy? You have to be certified to do it, and you have to be a dermatologist, I think. I don't know of other groups that do that. Because of the higher risk of cancer with applying or using those ultraviolet lights. So, but phototherapy can help in this situation, especially for more extensive disease. Okay, next page. Oral retinoids can be used. Yes, Jenna?
Are these treatments just for symptoms?
No, no. You are trying to arrest the immune response.
Okay. Did she just mention there was no flu?
Well, Lichen Planus usually runs its course over several years. Now, some I know you have to treat always, but my understanding is that some of them it's a 1 to 2 year, and then they kind of go away. But for those who have long term, then you might look at some of these other non-steroid treatments. So look on the top of page 10. So oral retinoids are an option. So this would be the same type that we use, or similar to what we use in acne. So Accutane, the isotretinoids would be in here. So there is a specific one for Lichen Planus, which is that acitretin. Look at all of the different types of interleukins and or inflammatory cytokines that it affects. So you've got interleukin 6, you have the migration inhibitory factor, and the interferon gamma. So you're hitting inflammation, that's the interleukin 6. You've got anti-proliferative, which goes to that MRP8, and their keratinocyte differentiation, which goes with the interferon. These are hard drugs to take. If you look down through there, they're second line because of their adverse effects. They're PO, daily for 8 weeks. Xerosis is probably the worst thing. Anybody ever taken Accutane as a teenager? It just dries out your skin. It dries up any oil that the skin can produce. Hair, face, anything. So people's skin peels, it gets very dry. They recommend they don't take showers because you can't produce any oil. Hair loss can occur. Triglycerides go up. It's one of the things that you monitor. Bone pain can occur. Liver enzymes. All of these are monitored when someone's on a retinoid. Similar, we'll see it with acne also. All the isotretinoids and retinoids are all very teratogenic. So for teenagers that are going to take it, or anybody takes it for acne, for females, every month you have to have a pregnancy test. They will not dispense it until you got a negative pregnancy test. For this one, it is recommended contraindicated for 3 years. After you stop taking it, 3 years, you are recommended you not get pregnant. So that tells you how strong it is. And probably very lipophilic. So the other treatment is antihistamines. So you've got steroids as your base. So what's going to determine what route of administration you use in terms of your steroid?
It's located.
Location. Okay, so where is it on the body? What else? Okay, how extensive is it? So the more extensive, then you might go with oral versus the topical. What else? So location not even goes to like organ, but the type of skin that you're dealing with as well. Okay, anything else? So that's your mainstay. Then you've got second line. So you've got the retinoids that you could use, and then you've got supplements. So you could use antihistamines. They are not going to be powerful enough because that itching is so intense, they will not be able to leave the areas alone. Okay. Anything that you heard about the Lichen Planus that is different from what I have told you?
The presenter mentioned using cyclosporin.
Speak up, I can't, the fan, my ears are all, just talk louder.
The presenter spoke about using cyclosporin, even though it's typically seen for psoriasis, they can apply it in chronic patients.
Did they say where in therapy to use it? I think it would be it's a very immunosuppressive drug, so that would probably be down the line, I would think. You sure don't want to have to use it long term.
She said for severe chronic disease, we could use cyclosporin.
Okay. All right, let's take a break and we'll come back. Psoriasis will be our big topic, and then rosacea. So we'll come back.